Hello, everyone. This is Robert Paler, former Cal rugby player and now executive director of the Big C Society. Together with us today are Joe Roof, the president of the Big C Society, Sean Paga, the liaison director for rugby on the Big C Society Board of Directors, and our special guest today, Dr. Ian Tong, formerly of Cal Rugby and more recently, the chief medical officer of Doctor on Demand, the nation's leading virtual care medical practice, and an assistant clinical professor of medicine at Stanford University Medical School. For the benefit of our listeners, Ian, I'm going to start with a little background on you. Ian is an Oakland-born native, was raised in Fresno, and returned to the Bay Area to attend Cal, where he was a member of 3 national championship winning teams and was a collegiate rugby All-American. In 1994, Ian graduated from Cal with his undergraduate degree in English, which we are going to have to dive into because I don't know how you went from an English major to a doctor. But before we get going any further, Sean, is there anything else you'd like to add to introduce Ian to our audience?
Yeah, no, can't wait to hear about that transition from English major to medical school. But yeah, no, Ian, thanks for taking the time. Obviously, you had a fantastic career as All-American and then transition into the business world and have done really well, not only as a doctor, but a doctor on demand, and then with the nonprofit work that you do with Rugby Opportunity Fund and the mentorship. So just can't wait for everyone to hear about your story and journey and some of the work that you're doing outside of work as well on the mentorship side would be fantastic. But yeah, I really appreciate you taking the time today.
Yeah, thanks, Sean.
Ian, thank you so much for being here. How are you doing?
Hey, you guys, thanks so much. Robert, Joe, Sean, I'm doing great. And, as great as can be when we are in the, at the hopefully tail end of a global pandemic. I mean, I think a lot of us have had the hardest years of our lives, probably. No, that's not, I don't think that's an overstatement. But we're all doing well. I've been lucky to have my family stayed healthy. And so definitely a privilege to be here with you all. There's some good friends on this screen that I'm looking at. And so I'm happy to share and do what I can for the Cal family.
Absolutely. Well, we're so happy to have you here today. And for my first question, I want to go back to that earlier comment, which is how you went from being an English major to going to medical school. Now, forgive my ignorance, but I was under the impression that chemistry, organic chemistry, or biology are the type of pre-med majors that open the door to medical school. Can you tell us the story of how you decided you wanted to pursue a career in medicine and that journey that took you from Cal to the University of Chicago's Pritzker School of Medicine?
Yeah, absolutely. Yeah. And it wasn't a straight path. I'll just say that right up front. Maybe to, kind of roll back the clock a bit. I was pretty, confident in myself and my abilities entering, I was a good student in high school, entered Cal thinking, I'm quote unquote smart. And so I said, I'll take Spanish 2 and I'll take Chem 1A and I'll take all this stuff together. And that was probably the humbling part of my background. They said, oh, well, that's really hard to do. And I'll join a fraternity. That was the other really brilliant idea that I tried to achieve all of that in the first semester of college. So I ended up on academic probation actually after my first semester. And I think it's important for everybody to know that this journey for me did not start on the smooth and easy downhill path to getting to combining my background and what I thought were my smarts to my eventual career outcome. So, but I did enter as a molecular cell biology major and actually struggled in that Chem 1A course. I did not pass the course the first time I took it. And that was a very important, humbling moment for me, because I think I learned right away that, this isn't going to be easy, one. And I think every person who, builds their grit and determination has to have that moment, honestly, where they're like, oh, it's not just easy all the time. So I actually had to face that when I was 18 years of age, kind of a couple months into college career. So that was really good. And I did. So my advisor said, you should change your major. And I did. I thought that was reasonable advice. The thing that I didn't like that they said though was, but you really don't have a chance. Like, forget about becoming a doctor. This is not an option for you. So that was all feedback that was given. I took some of it, right? Some practical advice seemed good, but I also blocked out the parts that I didn't think I wanted to hear. So I continued to take my science courses, and you can do that. And so a smart decision there is take coursework that you're interested in, that you can excel in. But if you have a career path, there's nothing wrong with you putting together the coursework that you need to also satisfy whatever that future career path is. And so I did that. So I actually took I took over half my pre-med still while I was pursuing another course of study that I was also equally interested in. The other thing, the reason I made that change was also I loved English, but also it gave me flexibility. So when I looked at across the 4 years, or at least the first 2 years of college and the molecular cell biology major, most of my coursework was predetermined of what I was going to be, what I was going to have to take. And when I looked at English, it opened it up, and I could take ethnic studies courses and film courses, and really take a lot more breadth of study. And so I took that approach to doing that. So the number one major, to answer your question directly, of like, well, how does that journey? How do you bridge those two? The number one majors or group of majors that for people who enter medical school are in the sciences, typically the biological sciences, right? So like molecular cell biology at Cal would be like that classic major that people then continue on, and then they go into, but there's no pre-med major at Cal. So you're in a field of study. But when I was looking to apply to medical school as a non-traditional student, and I looked at the statistics, and so I became a student of like, what does it take to get to medical school? I saw that, yeah, those sciences are the number one majors, or the most common majors. The second most common major, and I would say is a non-science major, actually is English. So English is the most common non-science major that people go to before they, that are actually gain admissions into medical school. So I knew right there was a story there that no one actually told me about when I was entering Cal and the pathway to becoming a doctor. But I realized that there's a whole lot of people in the humanities that do this other more broad course of study, but they can still gain admission into medical school. And so I was like, oh, I just got to figure out what that pathway is and make sure I check all of the right boxes and not give up on my dream if that is in fact what I want to end up doing.
Yeah, I'm really happy you brought that up because, as a recent graduate from UC Berkeley, I have friends who were looking to take that path in the beginning. And Chem 1A is known as one of those weeder courses. And there's a lot of people who have a really rough time. And then they hear those same words that you just told them. You need to pivot. You need to find a new career. This isn't the thing for you. But seeing you go through that period and keep your eyes focused on where you want it to be, it's evidence, of being able to take that journey to put together a formidable application and to pursue this passion that you want to pursue in your career. And I want to talk a little bit more about putting together that competitive portfolio to present to medical school. I know that the test scores are pretty consequential, or at least I've read that the test scores and whatnot are pretty consequential into getting into medical school. Can you talk about, studying for the MCAT, and do you have any study hacks that you could give to our listeners?
Yeah. Oh, this is good. Yeah. Really. Yeah. So real quick, one thing that's important probably about that. So first of all, when I was on academic probation, my mindset was like panic, right? I was like, uh-oh. And so I spent a lot of time thinking at that moment, what am I going to do? Like, and how do I, what am I going to do with my life? I didn't have the expanded kind of options there to think about. So we might want to get into that later, but I'll just summarize it to say, I entered college with a fixed mindset of who I was and that I was smart and I had skills and talents, and I glided on those probably through high school. But at college, Chem 1A was like, you can't glide here. Like, that's not going to be it. You have to be a hard worker as well. And so not knowing it, and because it wasn't called that then, but I think I learned to be a hard worker. That's one. That's what we'd call it then. But now I think we know enough from social psychology to say, actually, what I was doing though was I was changing my mindset from a fixed mindset to a growth mindset. And I think that's an extremely important thing for anyone that finds themselves in my position, but honestly for all of us that have high ambition and want to be successful. Ask yourself, what is your mindset? Do you see yourself as being able to do things, or do you see yourself as being able to learn things? And once and to apply hard work. And so I became a believer that the application that I could apply myself, and with effort, I could do whatever I wanted. And I say that because rugby and my experience as an athlete is like, I think I didn't learn those things independently. It wasn't just about schoolwork. It wasn't like a switch went off in my brain of like, oh, I'm fixed mindset, now I'm growth mindset. I learned about hard work and being challenged partially through my experience as an athlete. So then fast forward to like practically what do you need to do? So absolutely, when I graduated, I did have a bit of a problem. I had done really well in bringing my GPA up. I worked really hard, so I got it to the right place. I took some courses at Cal, but after graduating, I took additional courses, organic chemistry and other courses outside of Cal. So I did some of that at SF State. And then I came back and took biochem at Cal. So, you know, I kind of mixed and matched the pieces and the coursework together, but got to the GPA to what I knew was like, okay, this is like, you know, just above the minimum, but it's good enough. You know, for now, it should be good enough as long as I do well on the big exam, right? Which is the medical college admissions test, the MCAT. And so then I was working, I didn't have a lot of money, supporting myself, but there was investment. I could invest about 12. I don't know what it is now, but then at the time I think it was like $1,200, like, which is a lot of money, you know, to a new grad to take the course. But I just saw that as like over the course of a medical education, I'm going to invest over $100,000 probably in myself for this education. This $1,000 is 1%. So I'm just going to start my investment now. I'm going to pay for this course because to start that journey, I have to get at least a minimum score. And again, I learned from that. My weakest subject going in, in my mind, because of chemistry, was I'm not good, and the fixed mindset, I'm not good at chemistry. I need to work really hard on the physical science portion of the exam. It turns out that's what I scored the best on compared to all of my cohort that took the test that year. The thing that I scored the best on against all of them was the thing that I was the worst at in my mind going in. And so that's just a really good example of like, no, it's not about what you know and who you are, what you're good at. It's about what you're willing to put the work into.
Wow. That's amazing. What an inspiring story. And by the way, Ian, I was also an English major. So this is, I love the positive, you know, English major exposure going on here. So for the benefit of our student athlete listeners who are considering medical school right now, you know, I'm hoping you can paint a picture of what the experience is really like once you get there. So like, when did you start dissecting cadavers, and when did you start practicing slicing real people open and giving injections and so forth? And in order to absorb the encyclopedia of information about the body, you know, with unfamiliar names like aphthous stomatitis and bradykinesia and cholecysthiasis, like how much did you study?
Yeah, it's music. You go.
How much did you have to study daily? I mean, it just seems like from a practical standpoint, it must have been a lot, because those aren't like the most intuitive names. Let's just say.
Yeah, no, that's a great question. I mean, there's no question for sure. You have to love learning and you have to make a commitment to that. And what you realize really quickly is, you know, you're giving up going to maybe this event, and I missed a few weddings. I mean, there's no doubt that, I mean, there was just, I committed to burying my head in those books and so on to get there. But medical school, I'll be honest, once you get in, it's actually a lot of fun. So people should know that, like, so even though you are studying hard, and they often liken it to drinking from a fire hydrant. They just, you know, sort of like, you don't sit down in front of the fire hydrant and open up the thing and, you know, you get tumbled and blown away by that, right? You take little sips. And the good news is the things that matter appear over and over again. So there is some repetition, and you start to learn how your learning is layered and you get deeper and deeper. But you started with, just some of the initial coursework. I mean, I entered medical school again with that more of that humanities background, but I had taken all the tests and done all the required coursework. And so, but I had the advantage of entering a little bit older than my average age of my classmates. So I was about 26 when I entered, which, by the way, I think is a great age to enter medical school, because I had seen some things, I had worked a bit. And so I had made a decision there's no place I would rather be than in that anatomy lab learning, because I wanted to be a great doctor. And there was no question of that. Like, I knew why I was there and I knew what I was there to do. So I do think the maturity of a few years helped me to be fully committed to that. The first day of medical school, within the first 2 weeks, you learn and they introduce you into embryology and morphology. So really how does our early cell development inform the way the rest of the body needs to get mapped out? So that was kind of an interesting introduction. And I didn't realize I was ready to let's get into that anatomy lab and start doing that. But then they had this really cool process that's worth sharing to people, because I think it's a little bit of the art of medicine. But then we went through actually a ceremony, and we acknowledged the sacrifice that these people had given to science. They had donated their bodies to science for us to have the privilege of learning through their physical vessel how we can learn the proper placement, learn about some of their pathology. But eventually, we approached that with a great deal of respect. if you will, and ceremony to acknowledge what they were giving us. And then we entered into the lab, and then we were able to begin to learn. And we wrapped their faces and actually spoke to our cadavers. So people, by the way, don't think that that's a thing, but it was actually a really important thing, because you realize that person was an animate individual, right? They had family, they had siblings and spouses and children probably still on the planet living alongside us, but this is what they chose to give themselves to. So, but you spend, typical day, you're in class. Well, and at that time, the curriculum was much more classroom based. You're learning those basic sciences over again. Some of them, like biochemistry and things that you had learned before, you're learning again, but in greater depth and greater speed. And that's really the biggest difference, in my opinion, is like the speed at which they are giving you that information is much more rapid, and you cannot possibly absorb it all. But you work a lot in groups and learn in groups. And so we were, so it was really fun. And it was always almost like a part social, part learning, and learning from your colleagues, talking and interacting with the content. And so that included, as I said, standing over a cadaver and learning how to dissect out the heart and where the vessels are. We learned that together as a team. You might do physiology labs together. So a lot of team-based work, I would say. And then when you get into the clinical part, where you actually learn to give injections and suturing and so on, that experience is really interesting. In the third year of medical school is typically when people do that, and you go on rotations every 6 weeks to 12 weeks. You're in surgery or pediatrics or family practice. And so you're really like being immersed in a different culture every few weeks, and you have to fit the team of the culture. And as the third year medical student, you're like the lowest person on the totem pole on that team too. And so you learn not just the content and how to suture, but you actually learn, I think, probably more about professionalism. You learn more about team dynamics. You learn more about high pressure situations and making decisions. You're not asked to make them as a medical student, but you are asked to have integrity, because you might be asked, did you get all the information? And you have to say whether you did it or didn't do it, or you can fake it. Right. And if you get caught faking it, that's low integrity, and that's not good. And you look really bad if that happens. But you also feel like you look bad if you say, what, I didn't do that. And so I learned there, if I didn't do it, I'm a horrible liar. So I'm just better off just saying, if I didn't do it, I didn't do it. But I think you learn some really important things. And if we have time, but I think some of that does play out, in your career. Maybe just now I'll just say, I'll tell one story. People are sitting there thinking about this. And those integrity moments, everyone's going to have it as early, maybe in their career. For me, it's in medical school, where I'm afraid because I'm the low man on the totem pole, but I see something that's wrong. And so there was this a case where we had in the OR on the vascular surgery service, University of Chicago vascular surgeons consider, they're like very proud of themselves, and they should be, because they're an outstanding group. That's the group. The movie The Fugitive is based on the vascular. Like Richard Kimball is a vascular surgeon at the University of Chicago, and it's partially filmed there. So this is like these guys, they're friends with Harrison Ford and all that. Like, I mean, they're top of the top for the country and what they do. In one case, we had a patient who I just happened to review the cases for the next day, and I came across an allergy in that patient, and it said that they were positive for an allergy to an agent that we use in vascular surgery, almost in every surgery, called heparin. And so in the OR, I just happened to be in that case with one of the cases that I had reviewed, and they said, and the lead doctor ordered the heparin, and this is a doctor who was known for having large outbursts if something wasn't going well and they were not happy, and I was terrified at that moment, because I was like, well, do I say something or do I not? But I did, because I didn't really think about it that much though, because it was like, it's kind of like, I better blurt this out, because I was just afraid of what was going to happen. So I blurted out, this person's HEPA positive, which means they have this allergy, which means we can't give that medication, which means we needed to have a backup plan, which did not exist, which meant the whole surgery is now delayed and this person just went under. And so that's not good. That's about as bad a start to a surgery as you could have. And so we got yelled at and all of that. But it was funny. I never got in trouble for it in the back end. And I think it was partly because it was the right thing to do. And so, learned a lesson there of like doing the right thing. I never got patted on the back for it, but I also didn't suffer any harm for it. But yeah, there's a lot of learning in med school. You will be forced to learn about yourself and the content. But I think it's all good.
You spoke a lot about the things you learn in rotations, why you do it, and from what I've researched, it's one of the most important decisions that a student can make in medical school is what specialty they choose. Can you just go a little bit further in that rotations discussion and medical school discussion and tell us the story of how you decided to specialize in internal medicine?
Yeah, sure. It's a great question. So yeah, you're getting exposed to the culture of the practice of these specialties and also the content of what they do. And is it intellectual? So one, are you intellectually curious about it? That's important. Two, do you have the skills? If it's a technical skill, if it's like really fun, if it's neurosurgery, for instance, do you have the steadiness of hand and that you need to work in small spaces and for very long hours? And can you and are you okay with the pressure of making decisions that are life and death? Because that these are just sort of, there's some of these things that I would say are core components across all specialties, but they have different nuances in different groups. So one way people decide is like, well, do I like procedures, or do I like what are called often the cognitive specialties like internal medicine or pediatrics, where you're not doing as many procedures, but it's more getting that history, thinking about that patient, considering a broad differential, and so on. That's a little bit different on the surgical side, where it's a few things, but you still have to be decisive and you have to take action, and your action could be life saving or life causing. That's so it's high pressure, high reward there, I would say, versus the more cognitive specialties like internal medicine or neurology, for instance. There's specialties there. And then there's these hybrid specialties that are mixed, like ophthalmology or maybe dermatology, where it's a mix of knowing a vast amount of knowledge, but also, but there's a procedural component to it. And so for myself, in terms of landing on internal medicine, I really was deciding between general surgery, which for me was like the huge, like, or some version of, or maybe subspecialty surgery like urology or something like that, but where it's a huge rush to be able to go in there, do something very physical, and then walk away with a result of like, yeah, I know this was good. And that patient the next day, is sitting there talking with you awake again, and you feel really good. And they really are grateful for what you've done for them, versus that. But that might be it, then you're done. And then you see them in follow up, versus internal medicine, where it's a longer relationship, more longitudinal care. I might be with you for a decade or 2 decades of your life. I might see you through the birth of children, or your kids getting married, or your grandkids graduating from high school, and all of the while, though, taking care of your keeping your body in tune and healthy while you go through all those things. But we also might go through cancer diagnoses or the loss of your spouse, so that's a whole different type of journey. But I just found myself being drawn to the longitudinal journey, and the way and the behavioral aspects of that. The people, for me, actually became much more interesting, and I think I had to do some soul searching to come to that conclusion. Um, but I like the thought of having that long-term relationship with the patient, and being there with them, and being able to be with them through that life cycle was really important. The way that I looked at that, and I think this is a good, like, uniform way that all, like, if you're a med student looking at this, is do what I call a prospective retrospective, right? So they like, go look at your career, the 30-year, 35-year career you're going to have. Imagine yourself at that 35 years downstream, and then look back at your career that you've just had over the last 35 years and ask yourself, does it have the day in, day out, and the years of mastery that you want to look back over and say, I'm really glad that I spent 30 years working on and perfecting this. And then sometimes you end up with like, and where do you have fewer regrets? Is it that you weren't here or you weren't there? And that's actually how I landed on internal medicine. Just a couple concrete things I would say. I love working with people. So internal medicine allows you to do that, and building relationships. So working with people and building relationships is a huge piece. There was great breadth of knowledge in internal medicine, but there was also really great depth. Like, you could go into cardiology or gastroenterology or endocrinology. So I kind of felt like I could go deep if I really wanted to in a specific organ system or area or type of illness. So you have that, really, that breadth and depth. And then there's this education piece. And when I went to med school at University of Chicago, internal medicine you kind of ran the hospital, and it was a medicine hospital and a medicine program. And so I got to see that exposure. They ran the educational programs, for instance, for the medical students, teaching them how to become doctors. And that grew really, I was really interested in that. I was really, I saw it would be potentially a privilege to be able to do that. And we had great role models there that were doing that. And so all of those things for me drew me to internal medicine.
I really appreciate that criteria and the decision making and how that all played out for you and just continuing to follow this thread here of your career arc. It's my understanding that after you earn your medical degree, you apply for residency. That's the next step, right?
Yep, exactly.
So then my understanding is that you don't always get your first choice. So that probably explains how you ended up at Stanford, right? Can you talk a little bit about the application process and then paint a picture of what your daily experience was like as a resident? The hours you worked, the time spent in the hospital versus a clinic, your responsibilities and so forth.
Okay, great. Yeah. I won't walk you through the whole 3-year journey, but I would just say there is a funny story about Stanford. So, but I'll tell you about that. But yeah, you do apply to different programs. So the way I approached it was cities that I would want to live, that I was willing to live in, right? I was living in Chicago, great city. So my rule was, you better be a better city than Chicago, right? And so Boston was off the list. No, I'm kidding. Actually, sorry, but it was. Yeah, I wasn't going to go to Boston from Chicago. So I was thinking heading west or to New York City, to be honest with you. That was like kind of where it was going. I had the added complexity that some people may not be aware of. It's a matching program. It's a match. So you go in an interview, but you match to the program. So they have to pick you and have you on their list. So if they have 10 spots, you want to be in the top 10, or if they go, let's say their top 10 want to all go elsewhere, then you want to be but somewhere you want to be high enough that you get in there, right? If they go 20 deep on their list, you want to be in their top 20, and then you want to rank them number one, wherever you want to go first, right? Whatever your number one program is. I had the added complexity that I was going to say that people may not understand, which is I couples matched. My wife is a doctor. We met in medical school. Right? We had all the good stuff, right? Fall in love, and everyone who's watched Grey's Anatomy, right? There's call room activity. None of that ever happened. I never kissed anybody in the call room, but it's nice on TV. It looks good. Looks like fun in the call room there. I slept in the call room. That's about all I ever did there. But I met my wife there. We were couples matching, and so that means it's based on where the two of you can match together, not in the same program, but just in combined programs. So we were very lucky. I was very, very fortunate that Stanford was, her first choice, not mine. You're right about that. But they weren't going to interview me. So they interviewed me there, which I thought was so because of her. So there's no question. And I'll just jump to the end of this story, which is they did do that. But eventually, right, they did ask me, I became chief resident there, right? So I will just say this to people, their systems of how they choose and line that up isn't perfect, right? But there's no question that I owe it to my wife to have that opportunity, because they really were recruiting her, wanted her to be there. And so we were lucky to couples match at Stanford. Day to day, the work hours, I was pre-80-30, or we were pre-80-30. So that means 80-30 was the limitation hours that they said, doctors shouldn't work more than 80 hours in a week, and they should not work 30 hours in a row, or more than 30 hours in a row. I was before that. So I worked 38, 40 hours a time. I was there almost 2 days in a row kind of thing in the hospital, nonstop, other than like sleeping a few hours. But I can tell you that there's a good reason why they made those changes, because that was not safe for anyone, including myself, trying to drive home. The 80 hour, we easily blew past. We would joke that we were not even making minimum wage when we added up the hours that we were, and we were paid to some of, and Stanford residents were paid probably some of the best rates, if you will, in the state of California. But we were making below minimum wage when you added up the hours that you worked. So it is very long hours, but I will say that time goes quickly because you're learning, it's active, and you're doing the real job. So it's actually, it was like it's a huge opportunity for growth and learning that I would just, I would say anyone, even if you go to med school and you don't think you're going to practice medicine, I would honestly say, if you miss out on the residency, you are missing out on like the biggest, most important concentrated chunk of your training. Like you're missing it because you deal, that's where you deal with the life and death. That's where you perfect and master the specialty. And that's actually where you learn a ton of translatable skills, I would say, such as team management and decision-making and critical thinking. Like that's where that happens, that you could take to any career path after that, but you miss on getting those. You asked about typical day. So let's talk about the typical day. So those days would start early. You start at 5:30 or 6 a.m. to get up, depending on how many patients you're carrying on your service. the years are broken up: intern, second year, and third year of residency. And with surgery, it goes to 5. So usually the senior resident is the 5th year in surgery, or 4th or 5th year, or 6th year, and then in medicine it's the 3rd year. So you kind of have different duties, but at different years. But as an intern, yeah, you get up early, you got to round on all your patients. You're kind of on the spot. You are closest to the medical students, right? You're just ahead of them, so you're providing kind of near peer mentorship and teaching to them. But you're really in that in between spot, and the pivot between civilian or medical student, kind of about to become doctor. And then you're already a doctor as that intern and second year resident, doing the job and teaching someone else to do it while you're also learning from your senior resident. But you round in the morning, you collect your labs, you talk to the nurses, you find out what the events were of the night, and then you present. And you present every patient in your service to the team and the attending, and you're sort of critiqued on like how well you did. Did you cover everything? What's your plan? And so you're forced to come up with a plan to address every problem. So it's a good challenge of organization, integration of data. And then there's always, with medicine, these are not robots we're making plans for and working on. We also have behavioral components, substance abuse, depression, anxiety, personality disorders. Right? There's a whole human aspect that you have to account for. Social determinant issues. Do they have housing? Do they have they're getting a divorce? I mean, all these things all make a difference in these people's lives. And so you have to take some ownership of that to help them navigate all of that with their heart attack or cancer diagnosis. So you learn a ton in there. So as I said, I won't take you through the full 3 to 7 year journey of that, but you learn a great deal, I would say, about human behavior. And then you have to fuse that with what you've learned about the science to make the plan that works. And so, but yeah, did I cover like the day? Yeah, a little bit more
Yes.
about the day. As you go on rounds, you will see your patients. Sometimes you present in front of them, you include them and get their input. And then you lay out the plan. You spend the rest of the day kind of executing the plan, getting the CT scans, MRIs, and so on. You update one another all through the day. You write your notes every day. You have to write your note for every patient. That's sort of like when you're done with that, it's a little things decompress for the rest of the day. But then you might have to run off to clinic and then go see your outpatient clinics that are not in the hospital. Your outpatient patients who are not in the hospital. And so you're caring for them and kind of practicing a whole another type of medicine that's not as acute. And then you go home and you try to eat, have some bit of social life, say hello to your spouse or say hi to your kids. And then you go to bed, and then you rinse and repeat and do the same thing the next day.
Yeah, I mean, that's a demanding process, and you're bringing up the pay too, and you're making around minimum wage when you add up the hours, and considering the costs of going to medical school and becoming a doctor, that adds even more demands onto this period. Yeah, how did you manage the stress? How did you manage those demands? Did you have any system or hacks or things that you
There's a
did
couple
to get
hacks
through?
on this. So this is I'm
Yeah.
actually really glad you asked that, and the way that you asked it too. So there are some hacks on this one. So one I would say is you have to be valuing something else other than the pay, because there's other easier ways to make a living. So you can't worry as much about the debt and your hourly rate, because you are learning so much. So there's a lot of delayed gratification. And if you struggle with that, and you're someone who says, no, there's a better way, that's true. There's easier ways to do this. And so medicine has to probably have someone who's willing to see the long path and really value other things besides the financial rewards, because the financial rewards are pretty delayed. The way that I handled managing the tight finances early in medical, it started in medical school. The way that I did that is, one hack is, when you think about every dollar you borrow as borrowing 3 or 4. That's how I did it in my mind. I just said, if I borrow this dollar, by the time I pay it off in 20 years or 30 years, it's going to be actually $3 or $4. So did I eat out? When my friends all said, let's go eat at X, Y, and Z for lunch, I would say, I'll meet you there. I got to go to the microwave and heat up my lunch that I cooked on Sunday, and I made it all Sunday, and I'm going to eat that through the rest of the week. That's how I approach. So I almost bought no meals in the cafeteria. I almost went out to eat zero, like I did not eat out or take that lazier path of like just paying for it with borrowed money. I mean, if someone's paying for your med school, go at it. Like, have the supreme pizza deluxe. But I didn't do that. I made my meals because I knew and saw it as like, I was saving money. Another good example is like, I love music, and I had a good CD collection. I stopped buying any and all music once I started taking loans for med school, because no CD was worth $64 in my mind unless it was the 4-disc, set of NWA. I want to just be provocative with NWA or something like that. But whatever, whoever makes these compilations, that's about it. But no, I just decided that I was not going to spend money that didn't need to be spent, or I would revalue it as, well, what is it? Is it worth the 30-year cost, which is going to be 3 to 4 times? And I think that's probably a pretty good hack for folks. And then here's the final hack, because I'm at the other end of this. Like, I could pay off I still have, and I'm still paying my medical school loans today, right? Wow. I graduated from medical school in 2002. And you say, well, Ian, if you could, and I can pay them off, why don't you? I have the money to do it now. But for one, I like my mindset, as I said, of the growth. Like, I will wait to pay those. First of all, the interest rate's very low. I got that down. So it's the cheapest money that I've borrowed now. But I like the thought of still owing that money and still being able to say that I'm still working on this. This is still a journey. And so I'm going to just hold those loans for as long as I can. And hopefully when they're paid off, it doesn't change my mindset. But I think that's a good hack, because achieving financial success that's not an endpoint. Like, that's not going to solve all other problems, right? Or all the rest of your life, right? So that's just one component. Yes, it can decompress some things. It can make some things better. But for me right now, I feel like I'm getting more out of still being able to say that I'm paying that, and the mindset that it keeps me in is very valuable to me. It's like the competitor. I think that I probably learned that as an athlete, right? It's like, did you win a national championship? Okay, yeah, we did. Are you happy? I mean, I'm pretty happy today. Tomorrow, I'm happy. A week later, that was last week. Like, are we going to go win one next year? Okay, well, then we should be starting. Like, when do you guys want to start working on that? And some people, I was one of the people who said, well, I'll just take a little bit of break. I would do that. But was I getting in the gym? Yeah. I mean, but I'm going to go back into the gym, and I'm going to start that work. And that's going to add on and make us better next year. So I think there's some, again, good learnings there. And I definitely see the value in having, that's a goal for me still, that I'm just not ready to give up. I'm still working to pay off those loans for med school.
A super quick question, Ian, was there a cost of living loan that you could get as a resident who was, working below minimum wage?
There was an adjustment. I think there was an adjustment to our payment. Actually, we got paid money after residency because of money that was withheld that was not supposed to be. But so I think Stanford, because it is expensive to live there, I think we did get a little help. I think we got a little bit of a stipend to help us afford, living on the peninsula, which is, it's some of the most expensive real estate that there is. But no, I mean, I don't. But there was no like specific program you could apply to get like a specialized loan or anything like that. You could consolidate your loans and reduce your interest rate. But this really, like, I think I did. I was lucky that I attended a financial counseling session before entering med school, and so I entered with this, sort of the idea of like not putting anything on credit. Like, I never bought anything on credit, paid off all my credit card debt. And then when I was done, I haven't carried a credit card debt ever since. Like, there were just techniques that we were, and hacks, as Robert said, that we sort of learned in that course. And so I took it all to heart, but a lot of people don't get that kind of counseling. But you have to, Joe, but let me make sure I answered all of that question. You were, did I answer it?
Well, no, it just occurred to me that the things that you just articulated, that it is expensive to live on the peninsula. And if you're making lower than minimum wage, it might be hard to find a place to live, within.
It's a problem. It's a problem.
60 miles,
For sure. It is a problem. But Stanford did have a little bit of a lottery for, they actually did have this. I forgot. I didn't do it, but they did have a lottery for, there were only so many units. So, that's why it was a lottery. Most people weren't going to get it. So you could do that. One thing I should say in med school that I didn't talk about was I also took a job in med school. So, which is not easy to do. And I don't recommend it if you're not willing to like, you sort of lose on some social life and you lose on some of the experience. And I probably compromised a little bit on the learning because I actually was the audio visual person for my class. I got to med school early. I found the building facility guys, and I just said, "What jobs can I do?" And so they said, "Oh, well, we have these. Every class has this person that does that runs the projector or the slides for the professors." This is before everybody was on PowerPoint, so like you had to load a slide tray and all that. And so I do think anyway. Just another piece that I would just say, like if you can find those opportunities and you have the time and you're willing to make those sacrifices. You can take some of that under your own control. And it's a good point. If you can, going to a residency program, it's a good thing to ask about if you're going to go. Most people want to go to a city. They have limited housing, limited affordable housing. Absolutely. If you have a family already, there was some preference for that at Stanford. So there are programs like that do exist. Yeah. Thanks. You're helping me remember some things that I've forgotten. Yeah.
Well, hopefully we don't bring back the memory of you just eating rice and beans and rice every single day too. Now, continuing on this discussion, now we want to examine the various roles that you've occupied in your career, and the first of which being a physician for the VA Palo Alto healthcare system as its medical director, and the firm that you co-founded, Dr. On Demand Professionals. Can you describe to our listeners the responsibilities and day-to-day experience of working as a physician and a medical director? And like we were talking about residency, the work product you're responsible for. How much time do you spend with patients versus staff and so forth? What did you do and how did you spend your time?
For sure. That's great. Yeah. So I was coming out of residency, had a couple ways to look at this. There are jobs that were coming out that were being offered where it's purely clinical, right? And you're paid essentially on clinical productivity. And so there are private health systems or large hospitals and practices that I could have joined. And then there was the VA, which was really unique and staying on as faculty at Stanford. And that was the direction that I went. And so with the VA, I did get, I think the reason I like the VA job, it's a job that would be very hard to find now, but it allowed me to do a few things. One, there was the experience of rounding in the hospital, right? And taking care of those hospital patients. So I got to do that. I had a couple months every year that I continued to do that through my early career. And it's something that you learn well as a resident. And that's being like a hospitalist, let's call it, right? So I kind of had the opportunity to I wouldn't call myself a hospitalist, but there's a career where it's about hospital medicine, and I got to still do some of that and practice that type of medicine. Then I also was had my own clinic. So seeing patients in an office, developing those long-term longitudinal relationships that I talked about, that was really important to me. So that was a portion of what I did. That was about 20% of what I did. And then I had this opportunity to be a medical director, and medical director is I would say what I would call like a pivot position. You can be a doctor who's seeing patients 100% time, but then as you layer up into leadership roles, medical director can come pretty quickly, where you're put in charge of other people, clinic, maybe nursing staff, other physicians, but some combination of that. Other doctors and maybe non-physician staff. And that pivot position, I call it that because you're doing some administrative work, like you said, leadership, team development, workforce management, right? So managing the people and their work habits, but also still seeing patients. So that was where I lived for about 8 years in that hybrid or pivot position. And it's sort of like the entry level leadership role, kind of like next tier up from being full patient care. The roles come from multiple different reasons. I would just say one little hack there is if you're willing to do things and work on things that other people kind of don't want, that they don't want to do, or they might avoid, or they struggle with, that's often an opportunity for you. And so for me, it was working with homeless veterans. Homeless veterans were seen as a difficult group, tough patients, and a lot of people didn't know what to do with the social issues or the behavioral health concerns, substance abuse, and so on. And I felt like, well, I had been exposed to this. I actually have been, in college, I was exposed to people who didn't have housing. I would, telegraph in Durant and People's Park, like that didn't, that wasn't intimidating for me, for sure. And so I definitely embraced the opportunity to take on some tough, I just thought, yeah, these are tough patients. And if I can do this, I probably could do anything. So I took that, and so my career developed along those three pathways, of like administrator, clinician, and then educator. And so that gave me a lot of breadth in that first 8 years of my career. And I would say now you probably can do like two of those kind of, it's hard to do all three now. But that's your day is usually divided into like clinic, rounding in the hospital, which is similar to what I described in residency training. And then if you're an educator, you're doing some amount of work with your program, the people that are working with you, and the students that you're guiding around and basically mentoring to bring up the next generation of students. And so I was very lucky to get that opportunity to do the teaching piece because I was always interested in that, and ended up becoming a faculty mentor for the students at Stanford.
I've also read that you spend much of your time as a physician still to this day on telemedicine calls with patients. But first off, is that true?
Yeah, I still see patients. I'm much more heavy on the administrative side now as a chief medical officer. But absolutely, so maybe that's good to take a quick step back. So at the VA, the other thing I learned actually was telemedicine. In developing the homeless program and the outreach program there, I wrote for a grant for rural health. And that's where I stumbled on telemedicine as a modality. And so this is right around 2007, 2008, when the first iPhone came out and we didn't have a camera on it. But I kind of knew like one day it's going to have that camera, it's going to intersect. And so I learned as much as I could about that out of interest, not because I thought it would be my career. I just thought this is cool technology in healthcare delivery. And I had a very practical reason to be interested in it because I saw where you could deliver care that way. And some of my patients that I'm trying to take a mobile clinic to, if I could just give them a device, I could connect with them across distance anytime. And so that was an interest. And so that ended up getting me eventually recruited to help found that telemedicine practice of doctor on demand. And so, I was always doing it early in my career, and then now building a practice that does only that. And so I spend much more of my time now, with the recruitment, training, and business development of the practice. But early on, I was the first clinician and saw the first patient virtually on our platform.
So with those telemedicine calls, can you describe to us the skills and qualities you had to develop to like specifically do a telemedicine call, or any tools that you had to learn how to use to be effective in that kind of patient environment?
Yeah. So I went to Doctor on Demand early, seed round of their funding round. So this was like, we didn't have a fully functioning product. So there was a certain amount of opportunity to help build and design how a doctor would land on the platform and what that platform needed to look like. And then also what was the intake for a patient to come in through the platform. And so, putting those, putting that experience together, you kind of learn some things. So one, that it's like you're running your own show. And that's actually how I educated doctors about it a little bit. Just like, someone's going to pop on the screen. And as the doctor, they're going to be a little bit shocked that you're there. And then you need to actually bring that person into a comfortable environment. And so so you look behind me, it looks like a doctor's office. This is important, right? Like that the environment looks familiar to a patient, and it conveys professionalism and trust, and it's familiar. So that's all deliberate of that's behind me. So the patient knows and understands that they're in an environment that's safe and that there's a professional. And then the way that the doctor initiates the encounter really should set the guidelines. So for instance, I'm gonna help you, but there may be limitations because we're not in the same room, right? And so we acknowledge that up front. So that's a really important thing to do. The other skills are really, this is something that I taught at Stanford, physical diagnosis. So I was like kind of the bedside diagnosis doctor, like what does that heart murmur mean? And how do you assess volume status of a patient? Meaning look at if their neck veins, are they in heart failure or do they have pneumonia? These types of clinical questions require really bedside diagnosis skills. I took that and translated what I knew and was teaching there to medical students, translated it to a set of guidelines, if you will, for telemedicine, for virtual care. and kind of had to make it up because nothing like that existed before. And so that included, the ability to complete the exam. And how do you do that at distance? How do you use the patient and guide the patient through feeling for the lymph nodes and so on? And just thinking about how to do that and combining, I think, the educational background I had of explaining things to high-level learners who are medical students, but are much more like civilians than doctors when they start an intermed school, right? So figuring out how to like help them bridge that, I think helped me with figuring out what were the guidelines and what was the protocols that doctors should follow to make sure that these clinical interactions were going to be high value and give the doctor the information that the doctor needed to make clinical decisions.
Well, first of all, Ian, I think, thank goodness that you founded that business. The pandemic clearly put new stresses on the medical industry, and you guys, were, because you got this going earlier, we're well positioned to deliver the remote care people actually needed. So I'm wondering if you can opine a little more on what is the day-to-day experience of being chief medical officer like, and then can you contrast that to, if you can, just to like what it's like to be a physician in a hospital making the rounds and so forth. They probably are really different, but just be interested to learn more about that CMO role.
Yeah, they're really different, but I will say I do. So CMO, let's take on that one, and then I think some differences probably require some comment on like the health systems that that doctors are sort of raised to work in. But what I would say about chief medical officer, it's a role that often is defined by the skill set probably of the individual who assumes the role and in what type of healthcare organization they're in. So my guess is that CMO within a health plan or a pharmaceutical company might be a little bit different than what I do. But my role as chief medical officer at Doctor on Demand was really, you have the full responsibility for the care delivery, right? The clinical product, if you will, that is put forth, and the quality of that product, the culture that defines, the values and so on. Like that if you're the founding founding medical director or chief medical officer, like I was, like, I think you get to define a lot of that. You kind of get to outline, well, here's what we want to do. And so, and for myself, part of that was making sure that it was around access to care, high quality and low cost, which is called the triple aim. Okay. And so these are good things for people interested in healthcare should know. And that equation is value equals access plus quality and probably plus patient experience in a digital health company over the cost of all of that. Okay. So that's the equation. And I would add one more piece to the equation, which is also physician sustainability and satisfaction. Like the clinician satisfaction is super important to me. And so the CMO's role is to make sure that workforce is respected, cared for, nurtured, and that they can perform at the same way a coach makes sure you can perform at the highest level of ability and that you're challenged to do that. I would probably say that I borrowed some of the motivational pieces and factors from my coaches to say, like, well, this is part of my role. I'm a coach. I'm referee, setting the settings, making sure the rules are followed. Sometimes that means I have to penalize people too and say, like, well, you got to go to the sin bin here. We got to sit you out for a few minutes, right? Like, or what have you. Yeah, right.
Is that a rugby term? Did you just?
It is.
Sin bin.
Yeah, absolutely.
Don't want to be there.
Yes. If you're throwing too many punches in a rugby game, you can be placed out for a few minutes to cool off. And that's what we call the sin bin.
Yeah, one might be okay.
Yeah. Yeah, exactly. That's right. So so I think these are some of the roles of the chief medical officer, but then there's other roles too. So one, chief medical officer also represents the company externally. So you do a lot of external facing presentations, webinars, and I would say thought leadership. So you have to have a certain amount of presence either locally, but that could be statewide or across your whole specialty, or it might be nationally. And so physicians are sometimes measured on, well, what's your reputation? And is it at the national level or international level? And if so, that's what usually in an academic medical center triggers, oh, they are full professor versus being an associate or what have you. Now, because of what I've done is all outside of Stanford, it doesn't, that's why I'm still assistant professor, but because I've chosen a different path. But I would say, given the reputation at this point, it's national for what we're doing, as you said, with the need of, the need that we have for telemedicine in the middle of a global pandemic. There's no question that that accelerated. The last piece I'll say is business development. So business development is a big piece. So, there's helping clients understand how to translate what they knew as traditional bedside medicine to actually being of value in caring for their population. So large employers or health plans that have large populations of people are very interested in that triple aim of high, quality and low cost, but also access. So they understood, the way I see that and practice that is that chief medical officer role is through telemedicine or digital health practice like Doctor on Demand. But you kind of have to check, you have to check a lot of those boxes to do that well and credibly. And then I oversee, publication, the publication program that are the peer-reviewed data and content that prove that this actually does achieve that triple aim.
Did you have to understand very much the you just mentioned sort of like the BD, almost like partnership with other bigger organizations. Did you have to understand those organizations pretty well in order to be able to sort of make the argument that was persuasive?
Yes.
Or did you just sell your stuff and hope that they like it?
Yeah, it's a great marketplace reality, right? Which is like, we could just make our stuff. That might be a little bit more of the software model. Hopefully I don't get myself into trouble for saying that, but software sales friends of mine will say that sometimes is they're like, well, it works well enough, right? And we can sell this, and then, but then also but it doesn't do everything, right? It often doesn't do everything that's needed to like deliver what the full suite of healthcare services that are needed do. We can just use EHRs as a really good example of that. Like, electronic health records help on a lot of stuff, but most doctors don't like them, and it doesn't necessarily make them more efficient in doing their work. But absolutely, Joe, is part of the role for myself as a chief medical officer would be to understand them and their constraints or challenges in terms of how the system is built and fitting within that system to incentivize the doctor to do the right thing, to incentivize maybe the doctor to save on the cost, and not be penalized when they save on cost, right? And then and if you're the plan, like how, and also having a great experience for the patient, right? So it's a complicated equation to make all of those things meet. But that was part of my role, is to help figure out how to do that. And we took the approach of we're going to actually step outside of the traditional reimbursement system, and we're not going to be what's called fee for service. So we didn't make fee for service billing. We don't bill more based on the complexity, and we don't bill more because we do more for the patient. We actually said, well, there's just a flat fee for the visit. We're not going to upcode and we'll be worried about that. We just want to provide great service. We're going to do that efficiently. We'll figure out the efficiency side of it. As long as you can pay us this, we think we can do it affordably and lower costs, and we can do it at high quality. Anyway, so I'm just using Doctor on Demand as the example, but absolutely that's the challenge, is helping them understand that you can do it, convincing them of that. That was a pretty good size of my role. I was evangelical about it pre-COVID, of like having to kind of tell people and convince them to get religion on this. Post-COVID, I would say people are, everybody had to get religion on it regardless of what I said, so I just kind of said, okay, well, this is how we, it's more now explaining how we do it. I think people understand that it's a great experience. They can trust it. But now they probably have to kind of now figure their way through all the other competitors who have come in post-COVID to say like, well, we can do that too. Now they kind of have to figure out where the quality is. But I think it's overall a very good thing for our healthcare system, which many people in the system would admit doesn't work as well as it needs to right now for our patients.
You've touched on it a little bit in this conversation, but now I want to shift to talking about the intangible benefits of the thousands of hours you invested on the rugby pitch, training, treating, competing, running, so much contact, so much hitting. Our audience is interested whether the sensibilities developed as an athlete are transferable to post-sports careers. So for that, I'm going to turn the mic over to Sean.
Yeah, we've heard a lot about kind of the qualities and the advantages that you get as a student athlete. And so just love to hear, obviously, as a doctor, obviously a very high performance role where you've got to perform. And then on top of that, an executive at, one of the fastest growing companies. So I'd love to get a better sense, first of all, do you feel like what you learned as a student athlete has helped you in your roles in the workplace? And then second, you touched on some of the things that you got from Cal Rugby, and obviously there's core values in the program. You talked about continuous improvement, how you won the national championship and you're already thinking about the next championship. So I'd love to hear a little bit more about kind of, is it truth that you got some competitive advantages from your experience as a student athlete, but also like, what did you pick up from your time at Cal Rugby that's helped you be so successful in your career?
Yeah, no question. I think the one, you're challenged as an athlete, as a student athlete, right? Sometimes you don't feel like going to practice at the end of a long day and trekking up to Strawberry Canyon, up the whole hill. And then you're like, and then we're going to run, and then we're going to get tired and you're going to feel like throwing up. And then I'm going to let you recover for a few seconds, because this is a bit scientific. People probably don't know this about the rugby team, but they're not guessing, they're not just masochists. They know that to let you recover and catch your breath and then make you work hard again is actually what builds those championships, right? Like I think a lot of us probably saw that and was like, oh, I saw Jack Clark watching us struggle, and the whole point is to wait till we want to quit, and then push us a little harder, and then give us a break, and then make us jump right back into it. There's no, I mean, and so I think there's probably coaching books on that, or there should be if there are not, and he should write one. But so there's no question that I think embracing the hard work, but also embracing the pushing yourself to that self-limitation or your self-limits, and then being willing to go a little bit beyond that to see, well, how far can I go? But then having the discipline though to also say, okay, wait, this is now I need to pull back. That's the hard part. I think we count on our coaches to help us with okay, let's pull back a little bit, and now I want you to go again. So I actually think about a fair amount of that when I'm with my medical directors and the leaders in my practice that I'm working with. I use that similar philosophy with them. The other thing I would say is what you're building when you ask someone to go to the point of failure and then pull back and recover and then go to the point of failure again, is you're building grit. So I think there's no question that there's some really nice books on it. We talked about growth mindset, but Grit is a book that I think applies very well to athletes. There's no question that getting comfortable with being uncomfortable is a big part of it. It just turns out I learned that as a student athlete, and I think all student athletes learn that if they have good coaches or if they push themselves appropriately. That is one of the most translatable skills, I would argue, in your professional life as a leader, but also as a frontline agent or what have you. Just kind of going out and frontline sales, and you're going out there and you're getting doors slammed in your face, like having that grit and being willing to be in an uncomfortable place and learn from it, and then fail or succeed, coming back with the learnings to improve. That is like one of the most important secret, kind of secret sauce that you could have. The other thing I would say is the discipline around of showing up for practice and doing something that's outside of your studies and outside of partying with your friends or what have you, but actually committing to something else that is that's hard to do and even if you can just do it for 2 years, I'd say do it. Like you should do that in high school, because that will probably predict your ability to do it in college. And I would encourage anybody to do or everyone to do a sport, whether it's club or not or something, but or join a club, but do something outside of your coursework, so that you can build that grit and that commitment to something else. And then the final piece that I think translates, there's more probably, but I didn't write these down. But the fellowship that I think I learned with rugby is something that I think it's in all sports, but rugby has that unique way I think of. It's just part of the sport. It's part of the post game. You go hard against an opponent, and then you have the social where you then hand them a drink or feed them dinner after the game to say, look, we went at it pretty hard. We even got it. Yeah, we even, I threw an elbow, you threw a punch or whatever, or you gave me a hard tackle. but that was the game. And now we're all about something else bigger outside of the game. And that to me is, that's probably another like secret sauce that I definitely am using with my team. Again, it's not all about finances. It's not about buying additional houses. Like we have a mission that's around, transforming healthcare delivery in this country and doing it in a way that benefits the patients, but also is sustainable for the practice. And so I feel like those are all very translatable. And if the athletes, student athletes, recent graduates and so on watching this haven't heard this before, in professional life, those commercials about professionals being successful, student athletes being more successful as professionals, that's true. I mean, I think one of the most evidence-based backgrounds that you can find is whether about someone who's been professionally successful is whether or not they actually played collegiate sports. So that is something that I would say I know, and the people that I talk to that hire at executive level and so on, they find all of these translatable skills in student athletes, and they just kind of take them for granted. I think at this point that they are going to be there. Like that person's going to be able to collaborate, work in a team. They're going to be able to follow the other leaders. If a leader makes a decision, this is very applicable to rugby. A player makes a breakaway, that may not be the right move, but if that's their move, the rest of the team's got to get with them and get on their hip, and it makes it the right move. That's the kind of thing that I think builds successful companies. It's not that the leaders are always brilliant making all the right decisions. It's that the people that support them make every decision the right decision by executing after the decision's been made.
Ian, I just want to do a quick time check here. We have one final closing question. Do you have time for maybe 3 minutes?
Let's do it. Let me, yes.
Okay. So just another quick footnote. You were just referencing the book Mindset a minute ago. That's Stanford professor Carol Dweck,
yes,
who wrote that great book. Everyone should read that. And as you know, like 98% or so of our student athletes go pro in something other than their sport when they graduate Cal. And we've heard poignantly from this group at the Big C Society that this transition of self-identity really from athlete to the post-sports you is really, really hard. And people have described feeling untethered, deeply uncertain about who they'll become, how life will unfold, first steps to take, all this, and we're just wondering if like your mature self could give some, general guidance to your 22-year-old self. Like, what would you say?
It's great. Yeah. First, I'd say don't panic. You don't know how valuable you are in the marketplace yet, but other people do. So this is why you should not panic. I'd also say where you are on your trajectory at graduation is not, has no prediction probably of where you're going to be, in 20 years or 25 years. I wasn't able to envision the things that I was going to do later in my career. I never would have I could not have imagined any of this or written it down like that. That's if you're if you're able to have confidence in yourself, if you're able to not panic, and if you're able to chart the course of, what, I'm going to set a high goal, and I only can't get to that goal in the short term, but I can see some of the steps, and I'm willing to put in the hard work that will build me up to where in 10 years I will be there. You'll do it. Like I have no doubt that you will do it, because that's exactly what I did after I kind of saw it. It took me a year or two after college to kind of get that confidence and to get through the panic stages and to build a platform. I was like, okay, I'm making a living now, but is this what I want to do? And then make your decision and be very honest with yourself about that decision. Even if it doesn't become clear until a couple of years after graduating, if you're honest with yourself when you make that decision, there's no question that when you plot that 10-year course, let's just say, you'll achieve it. It's just, just step by step, being willing to put in the work, you'll be able to do it. And
one of the things we're doing here for as an example is we're showcasing people like you and lots and lots and lots of other golden bears from different sports all in one place to make the point that indeed it does unfold the way that you just described, and you will get there. So, there's a lot more here we could talk about, Ian. I'm just wondering if anybody wants to get in touch with you after listening to this, how could they reach you? Should they reach you through social media or email or?
Yeah, LinkedIn is a great way to do it. But
Okay.
my email is Tong, Tong at doctorondemand.com, and they can email me. And I'm I love this program. Thank you guys for doing it. This is it's a great way to connect us all. We share a campus, we share some experiences, we shared some classrooms, we share some learning. And I think we can look out for each other, one another's future success too. So this is awesome. I appreciate you guys for the opportunity to join you.
Well, Ian, thank you so much for being here. And from one Cal Rugby man to another, it's really a pleasure to be having this conversation, and the experiences you shared, the insights you have, the hacks and steps you've taken in your life to get where you are today is truly a gift. And I'm very excited for our listeners to be able to have that gift with them for the rest of their lives. So truly, thank you, and go Bears.
Go Bears.
Go Bears.
Bears.